Okay, it's online already. Yes.
Yes.
Good morning, good afternoon, everyone. It's my pleasure to welcome you all to today's at 2025 Asian Cardiovascular Clinical Research Seminar. Our session today about intravascular imaging in complex PCI. I'm Dr. Ahmad Fauzi Yahya, interventional cardiologist from Hasan Sadikin General Hospital, Indonesia. And I'll be co-moderating this session with my esteemed colleague, Dr. Ji Zhao from Fuai Hospital. We are excited to delve into the critical role of intravascular imaging in the management of complex coronary interventions. Today, we are fortunate to have a distinguished panel of speakers who will share their expertise and insight on this vital topic. Our first speaker is Dr. Ahmed Qasim from King Abdulaziz University Hospital, Jeddah, Saudi Arabia, will present on intracoronary imaging in complex ACS-PCI, why it is mandatory, followed by Dr. Donjin Fuai Hospital and National Center for Cardiovascular Disease, who will discuss intravascular imaging in CTO-PCI, efficiency and safety. Next, we are having Dr. Cheong-Min Lee from Tokyo Medical and Dental University School of Medicine and Tokyo, Japan, will explore intravascular imaging in calcifications from plaque characteristic to pre-interventional decision making. Finally, Dr. Ji Zhao from Fuai Hospital will provide in-depth analysis of interventional strategy for heavily calcified coronary lesions. Each presentations, we will have a discussion after the whole speaker talk about the topic, and we encourage you to submit any question you may have via chat function. We will make sure to address them during the discussion segment. So we are looking forward to a dynamic, insightful session. So without further delay, let's begin with our first speaker, Dr. Ahmad Qasim. Please, Dr. Ahmad.
Thank you, Mr.
Okay,
Chairman. Thank you, dear esteemed panelists. It's my pleasure to share in this seminar by talk the intracoronary imaging in complex acute coronary syndrome. And the question, is it mandatory? Of course, that the acute coronary syndrome, it is the most severe form of coronary heart disease and poses threatening to human life. But the question, what is the complex acute coronary syndrome? It is actually angiographically complex culprit lesion or angiographically complex coronary anatomy. Of course, complex culprit lesion, including intraluminal filling defect with consistency to thrombus or plaque ulceration or plaque irregularity or heaviness. And according to Ambrose criteria, the angiographic hallmark of complex culprit lesion, including haziness, ulceration, intraplaque dye, or intraluminal filling defects, and also the coronary anatomy, which is complex according to the randomized trials, with angiographic guided PCI, including long lesion and ostial location, heavy calcification, bifurcation, unprotected left mean, and CTO. All of us know that there is large variety of underlying mechanism for the acute coronary syndrome, including the most common atherosclerosis, plaque rupture, erosion, nodule, based on postmortem and pathological and imaging studies. But we should not forget the not uncommon of the acute coronary syndrome is like SCAD, embolism, spasm, Takayasu arthritis, myopericarditis, Takotsubo cardiomyopathy, or congenital myocardial bridging. But the question, does the treatment strategies the same for all these underlying what we need, not stent for treatment of acute coronary What we need is the accurate diagnosis of the underlying pathogenesis so we can treating precisely the patient according to the underlying etiology. Of course, all of us know that the angiography, it is a gold standard for coronary artery disease diagnosis, but there is some limitation, including 2D immunographic view, disease underestimation in 30% of the patient, or we cannot details of the plaque like the high risk features of vulnerability. So this limitation can causing misjudgment of the lesion, can causing suboptimal management. So what we need is a precise diagnosis, including the recent modalities, including IVUS and OCT. Of course, all of us know that the OCT, it is 10 times more than it tools has its own future direction. Of course, we try make hybrid combination of those tools in one catheter in the near future. So intracoronary should be part of PCI of acute coronary syndrome for identification the underlying cause and guiding the precise treatment plan according the underlying etiology. Of course, the studies like this papers about IVUS guided PCI in acute MI showing that the IVUS guided PCI had lower target lesion failure and lower major adverse cardiac events, and also the ADAPT DS study, which than 8,000 patients, and 39% of the patient used IVUS for diagnosis and accurate diagnosis. Of course, the group of IVUS guided PCI with larger diameter devices, high inflation pressure with lower definite and probable stent thrombosis in IVUS group, and also lower myocardial infarction and the MACE rate in the IVUS guidance group. The greatest absolute benefit of IVUS guidance were present in the acute coronary syndrome and in the complex anatomy. This also outcomes from the London showed the same results, benefits from OCT guidance more than the angiographic alone, and this also from Illumine 4 and OCT guide clear benefits. October trial, the same results actually for good business. And the European guidelines highlighted the importance imaging for intervention. Started from 2006, class 2 recommendation, 2014 European 2008 recommendation, and 2019. Recently, 2023 European guidelines highlighted that the is more preferable in the acute coronary syndrome with ambiguous culprit lesion. More, this is a very advanced step. Is recommendation by European team to a class 1A recommendation for using IVUS or OCT in the complex anatomy, true bifurcation or long lesion. And this is the European expert opinion. Coronary imaging is acute coronary syndrome, especially important when there is diagnostic and geographic uncertainty exists in of acute lesion, a clear culprit, but a complex anatomy. So we need imaging also with multivessel disease. We don't know hazy lesion, calcification, tortuosity, eccentricity. Also, we should need coronary imaging. Active lesion, what we call MINOCA. Also, it is very crucial for ruling out the underlying atherosclerotic rupture or erosion in the MINOCA group. Also, in coronary angiography, we should assess the by echocardiography. Should also further make MRI class 1A recommendation if there is wall motion abnormalities and normal LV, but Apex by echo, it is taxub clear, so we should go for management directly. So the data mentioned clear that the interim had changed the physician decision during the previous post PCI stage. actually 81% a change in the 9% treatment strategy, including lesion definition in 45%, including escalation strategy for lesion and the number of stent in 9%, total 30% of the cases, maximal stent diameter also has impact in the post PCI in 31%, including detection of edge dissection 5% and major malposition under expansion and so on. So it has major impact in changing the before or after intervention in the acute coronary syndrome. So what's important about the imaging in the acute coronary syndrome? Looking at pre-PCI assessment to morphology and the lens this of the morphology of the lesion in the acute coronary syndrome, looking for the culprit lesion assessment, lipid-rich plaques, fibrotic calcific, thrombus burden of this thrombus and of the plaque, erosion of the plaque or calcium nodule. And also we should looking forward for assessment of the plaque burden calcification. And a clear-cut CT is the preferred imaging for acute coronary due to high resolution and encroachment to the superficial layer with 10 more than the IVUS and of course the culprit lesion assessment because differentiation underlying pathogenesis is very crucial for best strategy for treatment of the lesion. For example, fibrous lesion should predilate aggressively NECP alone or even scoring or cutting alone, while in the lipid-rich plaques, direct stenting to avoid any distal embolization of the lipid core to making neuroflow phenomena and also the calcification. We should go aggressive modification of the plaques with tools. It has in the high-risk feature detection of the plaques, and except the outcomes within short and mid and long term if this plaque are there in the OCT assessment, including large lipid necrotic core and fibrous cap covering micron or high macrophage density and the thin cap fibrous aroma, spot microcalcification, black hemorrhage. All these features are present in 10 to 20 the atherosclerotic plaque, but 20% present in the acute situation, acute coronary genesis, acute coronary syndrome. And the lipid-rich plaque actually anidus and precursors for future rupture and development of the acute coronary syndrome if there is high burden of lipid-rich more than 180 degree, even in this case more than 36 degree. And also the lipid-rich plaques, we should expect that this patient term poor outcomes due to lack by the continuous uncontrolling of the risk factors. And also the presence of macrophage infiltration, especially at the tip of the thin cap fibrous aroma. Of course, in addition to the biomechanical stresses, the presence of activate, which can easily now detected by OCT, and it is validated by histological correlation studies. It is actually a marked vulnerability of the plaques by OCT. Also, intra-plaque intimal vasculature, what we call the microvessel. It is a small black hole easily correlated and validated by the histological study. It is one of the markers of the vulnerability of the plaques. And this important data showed that the presence of the some of this marker of vulnerability in the non-culprit adjacent lesion proximal LED is a very poor prognostic marker for prognosis and poor prognosis and progression of the underlying pathogenesis is less than 3.5 millimeter or fibrous cap thickness less than 75 or lipid arc more than 80 degree or infiltration of the macrophage. Predictors for progression of the disease and major adverse cardiac events within 1 year according to this data. Second, issue about the use of OCT in the acute coronary syndrome is also the burden, the type of the thrombus. Of course, all of us know that red is fibrin-rich and more commonly occlusive thrombus in the STEMI cases, while the white thrombus it is platelet-rich and non-occlusive thrombus, most common in the non-STEMI, and of course by OCT, high backscatters, high attenuation, it is red thrombus, or low backscatters, low attenuation, it is a acute situation. And this study correlating between the color impact of the thrombus in the clinical outcomes in 1 month, of course, showed that poor outcomes in terms of MACE rate and death and MI and revascularization and CVA, according to the KDROS. Another important point for the OCT and imaging in the acute coronary syndrome, of course, the detection of the underlying mechanism is the most common underlying pathogenesis in 64% of the cases, or the plaque erosion in 26% of the cases, or the calcified nodule. Of course, it is clear from many studies that the plaque rupture is the most common underlying pathogenesis for acute coronary syndrome, especially detected by OCT. And there's also paper comparing the plaque rupture outcomes and comparing to the intact fibrous cap or plaque erosion. It showed that plaque was independent predictors for worse outcome at multivariable analysis in comparison to the plaque erosion or intact fibrous cap. OCT is very crucial for differentiation between the definite erosion, what we call luminal thrombus in contact with visualized plaque, the probable erosion, which is irregular lumen without thrombus. And of course, it has impact in the non-stenting strategy according to this study, using in more than 100 patients, STEMI 94% of the cases, and using OCT in day 2 and day 3 to 6 and day 7 30, and of course they found that only 62% of the patient they need stenting, while according to the OCT study with erosion pathology, no need for stenting. It is just only medical management with antiplatelets in 37% of the cases. It is very crucial for decision making to deploy stent or to defer stenting or the rate according to this study. And also the role of the OCT in the acute coronary syndrome, one of the underlying pathogenesis, which is actually not commonly recognized, is the calcium nodule as a cause of the acute coronary syndrome due to high flexion stress, most commonly right coronary artery, and of course associated with thrombus. Of course, presence of the calcium nodule associated with acute coronary syndrome independent vulnerable plaque features in the OCT. And according to this study, the prevalence of the nodule, it is much more than 40% if there is maximum calcium arc more than 270 degree. But the question, is it bad or good? Nodule, it is smooth, it is a little bit not like the irregular or what we call eruptive calcium nodule with overlap thrombus. It is more worse in the treatment and even in the outcomes and even in the recurrence rate after the treatment of this eruptive nodule. But beyond of calcification by OCT in the acute coronary syndrome, we should differentiate between superficial or deep calcium, eccentric or concentric calcium, or eruptive or non-eruptive nodule, which also affecting decision-making and preparation of the lesion in this situation. And according to the OCT, we should scoring if the arc more than 180 degree, it is 2 points, thickness more than 0.5 millimeter, 1 point, and length more than 5 millimeter, 1 point, and or 3 or more, it is mandatory to make preparation of the lesion in the acute coronary syndrome. Another important points for role of the acute coronary syndrome complex anatomy, especially lesion length, lesion diameter, and of course, precise deployment of the stent should avoid landing zone in lipid-rich plaque or superficial calcium area. And according to the study, geographic miss is important predict failure miss rate. And of course, landing stent borders in vessel segment with more than 50% plaque burden in the IVUS or lipid-rich correlated to the incidence of stent edge dissection, restenosis, increase of periprocedural MI. So stent provide full coverage of the lesion from healthy to healthy as much as we can. And also we should mention using the EL to EL measurement and calculation of diameter for stent deployment. If a stent diameter decided based on EL to EL, we should rounded the diameter down to nearest stent size. While if we use the lumen for stent diameter, mean lumen diameter should be rounded up to nearest stent size. And also rule after development of the stent, post PCI OCT to rule out medial dissection, apposition, and expansion, and of course, they need after development of the stent in 25% of the cases to make more optimization to correct malapposition and the stent edge dissection. And also in ultimate trial, the IVAS observed only to achieve namely the minimal lumen area more than 5 millimeters square or 90% of distal reference lumen minimal stent area, black burden proximal or distal to the stent edge within 5 millimeter, and there is no edge dissection. This is optimal PCI according to lumen study. Very short case, a patient, 48 years old female, cigarette smoker, presented with anterior STEMI, arrested in the ER, and patient CPR successful to the CAST lab, showed normal right coronary artery, and this is the LED high burden of thrombus with occluded mid LED by what we call massive distal macroembolization, AVDE. And of course, after export aspiration many times and 3 times injection of medication inside the coronary artery and low dose intercoronary thrombolysis and resuming TIMI to flow, so we decided to go for OCT assessment. This ostial lesion showed that ostial high plaque burden in the ostial part and lipid-rich plaques in the proximal part, and the presence of the layered pattern of phenotype of this black rich with infiltration of macrophage in the superficial layer, and the presence of rupture of the plaque and distal shoulder of the lesion. And of course, despite this aggressive aspiration, still there is large red thrombus, residual thrombus to distal shoulder, and this red thrombus, of course, have impact in our decision decide to postpone stenting. According to the data published, according to the morphological predictor of neuroflow, it is concentric plaque. It is actually high risk for prediction of neuroflow phenomena if patient having high risk. And also the residual plaque after have very poor impact in the microvasculature and greater myocardial damage if you intervene with this huge burden residually after aspiration. So we should avoid. Also, the OCT showed that the distal shoulder rupture, high burden of thrombus, red type of thrombus, and the neuroflow complication much more common than the proximal or mid-segment rupture plaque, according to this study. So based on this OCT, I changed my decision actually. I decided to postpone the stenting of lesion, and of course, according to different STEMI trial, we gave the patient agrastat for 48 hours, and we bring him back. Patient resume TIMI flow after tirofiban, and we decided to deploy safely into the ostial LED, and this is TIMI 3 flow after we deploy the stent of this patient to avoid any vasculature damage or impact in the neuroflow if you deploy with this huge burden of thrombus based by OCT assessment. This case also with the patient having a stent to LED 3 years back, diagnosis as extensive anterior volume I, received thrombolysis. We day to cardiac image, right coronary artery and in-stent stenosis of LED of the oldest 10th 3 years. So the question for us, what is the insight for development of acute intensive anterior wall myoinfarction for this patient actually? So we decide the CAS lab and OCT. There is instant restenosis, there is intrastent intima hyperplasia, but most importantly, there is intima rupture inside the stent, intrastent new atherosclerosis rupture, which is actually vulnerability of the new stent, which is based on this OCT imaging. We cannot catch this diagnosis at all without intracoronary imaging. Of course, the intima have completely different titles than the new atherosclerosis or a new intima atherosclerosis with vulnerability, rich through channels inside the stent itself, even calcification inside proximal to the lesion. So this causes vulnerability is prone rupture at any time and development of the STEMI according to this patient. And this is the different types of lipid-laden neointima, heterogeneous type, and layered and calcification in the new intima itself inside this. It actually highlighting the importance of aggressive secondary prevention in such a group of patients. So my final take-home message, coronary or IVUS is mandatory in complex high-risk acute coronary syndrome. Intracoronary image gives sight about different acute coronary syndrome, black pathogenesis, pathophysiology, black vulnerability, and adding details to information about lesion, and which valuable to optimize for such difficult anatomy. Intracoronary imaging choice depend on lesion depth and lesion duration. Of course, OCT, it is excellent gold standard to layers pathology or IVUS or long lesion to assess the deeper layer of the and of course, in situation with STEMI and acute coronary syndrome, large residual thrombus, best assessed by OCT, it affects the decision which is safe to make differing of stent to avoid the microvascular damage and what we call microvascular nerve flow of this patient. Thank you very much.
So, uh, so thank you for Dr. Ahmed Qasim bring us very good presentation and a very interesting case. I'm really impressed deeply about your strategies and also your comment about this these cases and also how to deal with this kind of case. I think we can discuss in the last time of this section. Maybe I'd like to introduce the next presentation speakers, Dr. Yin Dong from Fire Hospital. Actually, he's my colleague, is a very excellent doctor. So, Dr. Yin Dong,
Yeah.
yeah, okay. So, Dr. Yin Dong is my colleague said he is a major in complex coronary intervention and intracoronary imaging and physiology. Also, he has do some research work and clinical works on coronary artery diseases. So please, Dr. Indo, please can give us your presentation.
Okay, thank you. Yeah, it's my honor to present this lecture. I think during the last decade, the interest in PCI for CTO has increased and leading to high successful rate. Failure to guidewire crossing is the most reason for failure CTO PCI. A better understanding of the behavioral guide wire within CTO segment may represent a key issue to achieve successful outcome. In this respect, I think iris imaging might have potential roles in the recanalization of CTOs and improve the efficiency and safety of CTO PCR. The iris has multiple uses for CTO PCR, such as resolving proximal cap and facilitating re-entry into the true lumen after subintimal crossing, and help troubleshoot when difficult traverse cut, and optimizing stenting after CTO recanalization. If there is side branch originating at the site of branch occlusion, the iris can be advanced into the side branch, and during the pullback, the precise location of occlusion and the presence of calcium are identified, which can help guide wire selection and shaping. The use of iris for stempless lesion is highly recommended by several algorithms for CTO PCR. Combined with contrast imaging, and iris can accurately determine the location and anatomic characteristic of the fiber cap, which directly influence the selection, shaping, and the puncture angle of the guide wire. There are two ways to support the guide wire engagement into the occlusion stamped by iris. The first is direct online guidance with the iris left at the site with the best view of the stamp, so that the wire position can be monitored online and the successful entry of the wire in the stem can be documented. Unfortunately, this method requires a large guide catheter to fit together iris and microcatheter. And the second disadvantage is the iris may diffract away guide wire and microcatheter. So in most cases, we choose the second method. We use the serial examination with iris. Firstly, confirm the site where the angiographic roadmap shows the iris transducer when the probe was detected. Then we choose iris probe. Once the puncture is made, subsequent iris pass again and confirm the intraluminal position of the guide wire. This is the case of LAD CTO, but we don't know where the entry point of the occlusion is, here, here, or here. Therefore, we immediately initiate iris to locate the occlusion entry. First, we pull back the iris from the diagonal, but found no sign of LAD entry point. Then we perform iris pullback from the septal branch, where we successfully identify the entry point of the LAD occlusion. And after correlation iris and angiography, we marked the entry point location. With the assistance of the double lumen catheter, we maneuvered the CP guide wire into the entry point and undevised it a few millimeters. Then we insert the iris back again to check the position of CTO wire. Unfortunately, the CP wire was in subintimal, which is a little bit distal to the real entry point. Then we left the first CP as a mark and controlled the second CP to puncture the different entry point a little bit closer to the first CP. Then result the iris to confirm the position of guide wire. This time we found the second CP within the stamp centrally. Then we change the double lumen catheter to Corsair and downgrade the wire to Pilot 200 and cross the CTO segment. And the iris pullback from LAD, we we can show the wire within the intrapark space at a whole segment. We can see some hematoma here, muscle bridge, and the landing zone is okay. So we implanted two stents and have a very good final result. In retrograde approach, using the same method, ours also can located in the side branch can clarify the retrograde guide wire position in CTO entry point and facilitate the re-entry in the true lumen. This is another LAD CTO case. LAD is occluded after the diagonal and the septal branch arise. After integrated wire escalation with ours failed, we changed to retrograde approach, but retrograde wire cannot cross the proc cap. With errors from diagonal conformation, the retrograde wire was in subintimal either. So we left errors in diagonal, and with real-time direct guidance, we can handle the retrograde wire to the true lumen here. Retrograde wire entering the integrate guiding catheter and implant the stent, and here the result. The second role of ours is keep intimal tracking and or subintimal tracking entry. When guide wire goes into the subintimal, ours will be inserted on the subintimal wire, confirmation of the position of the true lumen and the relationship with the guide wire. Then a parallel wire technique will be performed, guided by the hours on the first guide wire, handling second guide wire re-entering the true lumen. This RCA-CTO presents a very long occlusion segment, include two old stents with native segment in between. Using stent contours as a guide, we carefully manipulate the guide wire forward. The guide wire is UB3, pass through the first stent and pass through the middle segment and pass through the second stent, but was blocked at the distal cap of the CTO. And we tried integrated wire escalation, retrograde wiring, and parallel wiring, but all failed. So we decided to initiate ours. After 1.5 balloon dilation, ours was advanced in the middle segment of the stent, here and here. The guide wire remains centrally positioned. However, at the distal stent edge, the guide wire deviated from the central exit. As the guide wire exits the stent segment, it's into the subintimal space. Therefore, we performed the parallel wire at the initial deviation site to reposition the second guide wire back to the central axis, which was confirmed by the iris imaging. And after multiple fluoroscope angle optimization, we navigate the guide wires through the occlusion and access the distal vessel, target vessel. And our imaging confirmed that the guide wire remained within the true lumen throughout the whole CTO segment. After stenting here and here, and DCB here and here, the final result is acceptable. This is another case using ours to guide re-entry. The LAD CTO was tried at a local hospital a few months ago and failed. This time we performed the angiography again, which showed TIMI second flow and workhorse wire passed through easily. But our imaging showed the wire was in subintimal at whole middle to distal segment of LAD. Here is the true lumen. The wire all was in subintimal. We know the wire goes to fourth lumen at the very beginning, so we perform the paralleling wire technique, control the second wire to a different path. Yeah, here. So then we after hours confirm, we can see the second wire was in the true lumen. So we advance the second wire to the distal, and hours check again. The guide wire remain within the true lumen throughout the whole segment. We implanted a stent at the middle of LAD and left the distal segment healed itself. After 3 months follow-up, angiography and hours imaging showed excellent procedural result. And after wire crossing, ours can identify the intraplaque or subintimal tract. Sometimes subintimal stenting may be leading to disaster. For example, this RCA-CTO case, after antegrade failed V-trans to retrograde, the vessel was extreme tortuous, making wires overlap challenge, requiring bidirectional knuckling and reverse cut success. But our imaging showed wire within the subintimal space at CTO segment and near the advential. After stenting, we found contrast leakage and hemodynamic instability. Then we implant a covered stent, sealing the perforation. Another RCA-CTO case also failed previously. Also recanalized by knuckling and reverse cut. But after hours check, we found, here's the true lumen, but here's the subintimal. And when back to proximal, we can see the subintimal space is almost out of the vessel structure. So we did not stand in due to concerns of perforation. And the third role of ours is help troubleshoot when difficult reverse cut. There are 4 possible anatomic situations in which the antegrade and retrograde guide wire could be engaged in the CTO body. This situation can be recognized only by hours evaluation. The hours guided reverse cut technique offers the following advantage. The first is evaluation of antegrade and retrograde guide wire position. The second is choosing the optimized balloon sizing for media disruptor. And 3 selections appropriate position within CTO segment. This was a proximal RCA-CTO case. The antegrade approach using part 200 guide wire advanced the middle segment, but entered the subintimal space. The retrograde anteplane is part 200, failed to engage the guiding catheter, and the reverse cut technique was also failed at the proximal site. So we initiate hours imaging. Hours over the antegrade wire can confirm the exact position of retrograde wire in the true lumen at the middle CTO body, but at the proximal segment, the retrograde wire is in the subintimal. So that was the reverse cut technique unsuccessful at this site. So we choosing middle position to perform reverse cuts. The retrograde wire easily enter into the gazella, and the procedure was efficiently complete with optimal result. Finally, ours is able to optimize stenting for CTO. Also, ours guided stenting helps to avoid contrast injection that could worsen subintimal dissection. Ours is able to provide information about lesion length, morphology, and identify the landing zone for stenting. After stenting, expansion apposition can be optimized by our assessment. Also, ours is useful in side branch protection. This is a LAD osteo CTO. After ours guided entry, the CTO was recognized by Stingray ADR technique. And ours imaging can identify the landing zone here for stenting. We implant two stent from middle to the proximal. This is the angio result. Although the distal part was very ugly from angiography, but ours confirmed that is the negative remodeling and the stenting landing zone is very okay. And the side branch protection after CTO recanalization also is very important. The CTO PCI trial shows suboptimal recanalization, such as side branch occlusion, was associated with significant high long-term incidence of MACE. And this is the LAD short CTO. After wire recanalization and stenting, the diagonal was occluded. And when we back to check the hours before stenting, we can see at CTO segment, LAD wire and the diagonal branch were in different spans. When LAD stenting, the diagonal branch was compressed and occluded. Different meta-analyses have reported the advantage of ours guided over angiography guided PCR for the entire cohort of patients. Also, we can expect the hours useful for stenting optimization in CTO PCR. Prospective RCT has examined the role of hours in stent optimization during CTO PCR. This trial randomized 402 patients with CTOs to hours guided or angiography guided stenting. After 12 months, the incidence of MACE was lower in the hours guided group, 2.6% versus 70.1%. So this is a summary. In CTO PCRs, I think hours can facilitate case efficiency, and hours to guide stent implantation might improve patient outcome. Further studies with the large patient population are required to better determine the clinical impact of hours guidance for CTO regions. Thanks for your attention.
Thank you, Dr. Donyi. Very nice presentation, as comprehensive presentations regarding the intravascular imaging role in CTO PCI. So without further ado, we are going to invite Dr. Cholmin Lee from Tokyo Medical and Dental University to present his topic. Please, Dr. Lee.
Okay. Can you share my voice? Okay.
Yes, very clear.
Mhm. Okay, so I'd like to talk about the intravascular imaging in calcification from plaque characteristics to pre-intervention decision making. It's a great honor to present here. I have nothing to disclose, and this is the agenda of this presentation. First, and why intravascular imaging in calcification is important, because an intravascular imaging IVL-guided PCI has been revealed the better clinical outcomes than non-guided PCI, and particularly in complex region subsets. And this and the meta-analysis showed that IVL-guided PCI with DES was superior to the angio-guided PCI in published in Lancet in 2017, and about 30 to 60% event reduction was achieved. The another meta-analysis showed that 29% of target lesion failure reduction was achieved in the IVAS or OCT-guided PCI than angio-guided PCI. And this report showed that major adverse cardiac event was 43% lower in patients with imaging-guided PCI in the severely cultured regions. So the imaging-guided PCI is very important, and especially in the severely cultured regions. So you're in the Europe and the United States, and PCI Society showed that the management of the cultured coronary region statement, and they reported that the imaging guided PCI is has an important role to treat the severely cultured regions. And not only in pre-PCI, but also post-PCI. And also the SKY expert consensus statement and shows that the imaging guided PCI is important and for the decision making. Also in Japan, PCI Society and showed that the PCI statement for the cultured region. So I'm right and move on to the IVI imaging in calcification characteristics. And as you may know, and there are several types and several terms of the calcified plaque, like the superficial calcium sheet, calcium protrusion, eruptive calcium nodule, and the non-eruptive calcium nodule, and a lot of names. So and at first there is only calcium nodule, but now there is two types of calcium nodule, eruptive and non-eruptive. Also, there are two names of the calcium convex types of calcium plaque, and protruditing calcium and the non-eruptive calcium nodule. So we now slightly confused. And but in the calcium plaque pathological study of the calcium plaque, histologically, then the intact fibrous and calcium nodule was defined as the disrupted fibrous cap with thrombus, and when there is an not intact fibrous cap and no thrombus, that is an non-eruptive non-nodular calcification. Slightly different from in the pathological study. So, and I summarize the name of calcified plaque than in OCT and the pathological findings. And the OCT eruptive calcium nodule is equivalent to the pathological calcium nodule. And the OCT non-eruptive calcium nodule is almost equal to the pathological nodular calcification. And but an OCT protruding calcium is slightly same as the pathological sheet calcium, but not one-to-one correspondence. So, and the intravascular imaging can differentiate several types of calcium plaque, especially in OCT, but not always corresponding to the pathological findings one-to-one. That is important. So, and we moved on to the IVI in pre-PCI decision making in calcified region. So at first, as we are I'm talking about assessment of calcium stability, and to make the strategy for the PCI for calcified region, the assessment of calcium stability and the device selection is important. So, and to assess the calcium stability, intravascular imaging is very important, especially in the OCT. Because OCT is a high-resolution imaging modality and clearly visualize calcified region and qualitatively and quantitatively. And in not only in the noble region, but also an instant region. As you can see, and in the left side, compared to the IVAS images, OCT can clearly visualize cultured region. And also in the right panel, you can see the stent strut in the cultured region by OCT. As you know, and the OCT calcium score is widely used in the clinical settings. And Dr. Fujino, she is my she was my colleague in the CRA and Columbia University, and she reported that the OCT calcium score is very important and useful to treat the cultural lesion at pre-PCI. Also, there is another CRA and Columbia University team and reported that IVAS calcium score and slightly different from the OCT calcium score. And as you can see, the more severe calcium is scored in this paper. So IVAS calcium score is slightly less scored than the OCT. And why the pre-PCI calcium stability was important? Because if we don't assess their calcium stability and stent was not well and expanded, and as you can see, and in this patient, and angiographically not bad, but I was showed and stent is underexpanded, and after 40 months later, and stent was not expanded, and he came from the severe angina. So, and we need to treat and intravascular lithotripsy everywhere inside the stent, and you can see the clearly expanded and calcium fracture. So, and to avoid the stent and the expansion, and pre-PCI OCT calcium stability assessment is very important. And another option is a laser. So I reported the CHIMA laser is effective to the underexpanded stent. So, and device selection and wire bias is also important to treat severely cultured region. And as you know, calcium modification device is now available in like this slide: rotational atherectomy, orbital atherectomy, intravascular lithotripsy, IVL, and excimer laser. Also, a European consensus statement showed and reported that these lithotripsy and rotational atherectomy, orbital atherectomy, and laser is recommended to treat the cultured lesion. So, and to treat cultured plaque, at first, intravascular imaging is important. And when intravascular imaging catheter passed, calcium stability and the calcium type of calcium plaque assessment is needed. And if there is severe calcium, atherectomy like rotational or orbital or IBL is recommended. And also, when intravascular imaging catheter could not pass the lesion, and atherectomy or laser or small band dilation, and again assessment is important. And this is a case of the rotational atherectomy for the severely cultured lesion. As you can see, LAD ostial region and show the resting index and as 0.555, and we treated here with a rotational atherectomy. And pre-PCI OCT shows the guide wire and OCT imaging catheter is contacted to the culture nodule and the culture region. And this region has a OCT calcium score as a 4. So we perform the rotational atherectomy, and you can see the clearly modify the calcium nodule and the culture region, and after rotational atherectomy and the cutting balloon and the final OCT. And this is a case of orbital atherectomy for the culture region. As you can see, about the extent and in the LED mid and 75% stenosis and with the eccentric cultured graph by OCT. And you can see a good wire bias by OCT, like they are meaning their guide wire is contacted to the cultured region. And but if we use the rotational atherectomy, atherectomy bar may cause a normal vessel injury. And on the other hand, orbital atherectomy retrogradely, and and we can perform the PCI safely. So we perform the orbital atherectomy. So, and if you can, as you can see, and after the orbital atherectomy, we can see the cultural modification, and after balloon dilation, culture fracture was achieved. Also, and as you may know, orbital atherectomy and rotational atherectomy slightly different motion. As you can see, the orbital atherectomy is and different bidirectional and but rotational atherectomy has front cutting. And advantage of orbital atherectomy is in retrograde sanding and the bipolar wire for the orbital atherectomy wire is easy to manipulate than the rotational atherectomy wire. So, and if wire bias is good, and the atherectomy, rotational atherectomy or orbital atherectomy is good option. As you can see this region, and you can see the wire and the OCT image cluster is contacted to the culture node region. So we can ablate the culture node region and like this. However, if wire was biased to the normal vessel and like the BAT guide wire bias, we can ablate the normal vessel like this here, like here. So as you can see, and the intima and media was disappeared, and normal vessel was injured. And after that, and after the orbital atherectomy, you can see the coronary population here. So and the pre-PCI OCT imaging assessment is very important to avoid the complication like the coronary population. So, and past I reported the pre-PCI OCT findings can predict the normal vessel injury like this. Some OCT imaging cluster contact angle and guide wire contact or not is important factor. And if the OCT angle was more than 90 degrees and the guide wire contact is no contact, and we can see there are no and complication. And in past published article, we can see the OCT and normal vessel injury like here. So the if wire bias was not good and bias to the normal vessel and intravascular lithotripsy and shockwave is one of the good options. Like here in this case, and we perform the IVL. And as you can see, wire is not contact to the plug, but IVL can clearly modify the cultural plug, and we can get the enough expansion. And Dr. Giattari also reported that eruptive culture nodule is in eruptive culture nodule, IVL is and made and effective. And also, our team reported the IVR with orbital atherectomy is and the IVR combination is and effective. Finally, and I'm going to talk about the and stentless PCI. And we reported that DCB with an after orbital atherectomy is non-inferior to DES implantation for the severely cultured region required orbital atherectomy. And we found there and 1 year MACE was feasible in DCB group than DES group. Also, and DCB after a shockwave for culture region is also reported was feasible. We reported case and some case series in recently, and T-target region failure was 8.9% in patients with IBR and DCB for tenable culture region. And so culture region with DCB might be one of the options. And also, I reported the predictors of target region failure after PCI with DCB for de novo region, and we found that severe calcium is and less absence of the medial dissection on OCT is predictors of this the target region failure. And but in subgroup of the medial dissection and regions with medial dissection, cultured region and non-cultured region is not different and event frequency. So if the root expansion and on OCT with medial dissection, cultured region also we have the another and an alternative option with DCB in cultured regions. So this is a take-home message in this presentation. Intravascular imaging is important, especially in severe cultured region to assess the not only cultured blood type, but also decision making. In OCT-guided PCI for the cultured region, considering the wire bias, we can ablate culture region more effectively and avoid complication. Intravascular lithotripsy and shockwave is a good option when wire bias not enough, and the stentless PCI with DCB may be an alternative option. Thank you for your attention.
Okay, thank you, Dr. Lee. Very nice presentation. I learned much from these presentations. So I'd like to ask Dr. Ji Zhao from Fuya Hospital to present the last presentations, which he's going to talk about interventional strategy for heavily calcified coronary lesions. Please, Dr. Zhao.
Okay. Thank you, Dr. Mofosi. Is my voice clear?
Yes, very clear. Very
Okay.
clear. Very clear. Yeah.
Oh. I'm sorry. Oh, I want to share my, okay. Okay, can you see?
Okay, good, very good.
Okay,
Yes.
thank you very much. Okay, good morning, everybody. So it's so nice to be here with you. It's my sharing some interventional strategies for heavily calcified coronary lesion. So I'm Dr. Zhao Jie from Fry Hospital, Beijing. So as many doctors know, so the calcified coronary artery lesion is increasingly common and is associated with high rate of immediate procedure failure and adverse clinical outcomes. So the prevalence of coronary artery calcification, in fact, is age and sex dependent, being more common in the man more than 70 years old and influenced by imaging modality adopted. So if only invasive coronary angiography is used, so the prevalence of moderate to severe calcification according to studies with core laboratory angiographic assessment is between 20% to 30%. So therefore, advocating the need for adjunctive placar modification technique is likely in 2 or 3 out of 10 contemporary patient undergoing intracoronary angiography. So the challenges of calcification intervention. So severe coronary artery calcification is one of the main cause of procedure PCI failure, including impeded the advancement of device and render the stenosis no dilatable and instigate PCI-related complication, including vessel dissection, perforation, or mechanical stent problems like stent under expansion and dislocation, and also the dislodgement or loss. So the coronary artery calcification is also associated with the high rate of clinical events, including peri-procedure MI, target lesion revascularization, MIS, and the mortality. In addition, the presence of calcified nodules has been shown to be associated with a smaller minimal stent area, reduced stent expansion index, and higher rates of stent malposition and stent edge dissections. So, as mentioned, as Dr. Lee mentioned, so we know after 8 years, in 2023, the ESC published the consensus on coronary artery calcification management, with some new guidance. So we have many tools to assessment of to assess the coronary artery calcification, like CT and the calcification score and the imaging the angiography, and also the intravascular imaging, uh, like OCT and IVUS. Each tool has his own advantage, disadvantage. So in many cases, we can uh, use intravascular imaging to give us much more details information. So usually we use IVUS and OCT in some very calcified, uh, heavily calcified lesion, coronary lesion, according to the consensus. So we know IVUS can quantify the calcification by the size of the circumferential arc and by the length of the calcified segment. Also, IVUS can determine whether calcium is nodular, superficial, or deep. So IVUS detected calcification, and IVUS derived scoring system are known to predict the stent under expansion. Also, OCT can quantify the calcification by the size of the circumferential arc, thickness, longitudinal length, and depth, area, and the three-dimension volumes. And OCT, the CS system, can also has been shown to predict a stent under expansion. So until now, we have many weapons and techniques for coronary artery calcification, like some special balloon, like cutting balloon and NSE balloon and the Scroflex balloon, and also the grip balloon. And what's more, we also have the ELICA, the laser, and the orbital atherectomy, and also we have um, the IVL technique for the heavily calcified the lesion. Okay, so if we choose this kind of tools to deal with the heavily calcified lesion, they have actually they have many different different actors. So
according to some report, we can find actually use the rotation atherectomy is mostly used. So if we only use the coronary artery angiography and the CT, we can during the procedure, and we can use the stent boost to find if the stent is good expansion. If not, we shall use much more aggressive procedures. But uh, also we can use the intravascular imaging system to find to give us much more detailed information and guidance for if we can use such like special balloons or rotation as atherectomy or RVL for the heavily calcified coronary lesion. So here I like to share some cases. The first case is a 55 years old male gentleman. So he has a very complicated clinical history. Underwent many times of myocardial infarction and received PCI many times. So we can see this patient confirmed a very serious chest pain. So we can see the LED lesion is very heavily restenosis, instant restenosis in the middle of LED, like here. So first we use a small balloon, but the small balloon cannot cross the lesion. So you can, the gynae catheter is push out. So we choose the laser, 2.9 millimeter laser catheter. After the laser, so we can use uh, the 1.2 balloon can pass through the lesion and dilate this lesion. Then we use NC balloon, but we can see it cannot dilate completely. So here is the imaging. So also we use the laser again. Then we choose NC balloon after twice after the laser. So we can see the balloon still undilatable, but better than last time. At that time, the patient complained chest pain. We can see here diagonal disappear. So at the time, we choose rotulation as the RA operation. So first we choose the burr 1.25 and then the burr 1.5 millimeter. After this, we use a grape balloon to dilate. You can see the balloon dilate well. So this is the after the balloon dilation, you can see here the diagonal appeared. Then we use DCB balloon to deal with this lesion, and so this is final result. In this case, we use rotation atherectomy and also the laser together. We call it laser. So the second case is a 70 years old gentleman, also complaint chest pain tightness for 1 years. It's many risk factors. So we do the angiogram at on this is still so during the angiogram we can see the LED and also the LED and circumflex is very heavily calcified and very uh, uh, serious stenosis. So first we like to deal with the LED lesion, but you can see the microcatheter cannot cross the lesion. So we choose root ablation atherectomy. We use the burr 1.25, but the lesion is very heavily calcified and also is very long. So during the rotulation procedure, we deal with very carefully. During the procedure, we can see the burr entrapment cannot pull out. So
we use some special schedule to pull out the burr, and we still change the root wire, and we choose a rotulation again. So we use a new burr 1.25 to rotulation the LED laser because it's too long and tortuous. So the burr is easily to be entrapment. But at that time, at the second attempt, so we successfully to finish the rotulation procedure. So when after the 1.25 burr, then choose the 1.5 burr. So a larger burr was used after the rotulation. So the root wire entrapment again. So we use a microcatheter to pull out the root wire, and then we change it to the workhorse wire. So it's a whole LED lesion after rotulation hysterectomy. Then we use NC balloon and the first stent deliver with assessment of Godzilla catheter. So this is the first the first stent. Then we deliver the second stent, but this stent is uncrucible. So we use the NC balloon to deal with the lesion, and we deliver the second stent. So here you can see the stent is uh, some under expansion here, but it's acceptable. Even we use the very the NC balloon to dilate, but still here you can see the stent is under expansion. But the blood flow is okay. So TIMI 3. So we end the procedure at that time. So it's 1 month later. The patient come back again because his sunflex is still has some serious stenosis. So at that time, we use a microcatheter to exchange the root wire, but the microcatheter uncrossable again. So we just manipulate the root wire to cross the lesion and start retablation procedures. So we choose burr 1.25 and then after this we change to the 1.5 burr to relation the lesion, and after relation we deliver a stent and use NC balloon to dilate. We can see the final result. The sunflex stent is expand well. So 2.5 months later, the patient still confirmed chest pain. So when he came back, we checked the angiography, but sunflex is okay. But here the LED former stent is still underexpansible. So we check OCT found here. It's very serious stenosis, intravascular intra-stent stenosis, and also here. So at that time, we choose RVL. So this RVL, after the lithoplasty procedure, you can see check the OCT again. We found it's better than before. Then we use DCB to deal with the whole lesion. So this after RVL, so you can see here, and also uh, the stent, the expansion is better than before. So we also have the third case is 84 years old male. So after shortness of breath for 1 month, so echo shows bicuspid aortic valve and severe asthma. So also the eject function is very poor. It's 38. So the CT scan show us type 1 BV. So we plan to do the PCI, the TAVR, the same procedure. So you can see here the LAD is very serious stenosis. Maybe we want to check IVUS, but you can see the IVUS catheters are very hard to push advancement. So we check the IVUS, so it's very serious stenosis, very serious. Also the calcify is heavily. So we choose RVL, the lithoplasty, 3.0. You can see is after 7 round, and the balloon is dilate completely. So when we check iris again, we can find some ruptures here, after the uh, lithoplasty. So we then we put a stent here. You can see after the stenting, it's good. So we checked IVUS on the stent expand good expansion, and also it's very acceptable. So then we put the TAVR, we do the TAVR procedure here. So the patient is good. So the last case is 61 years gentleman whose effort chest pain for 22 years, exacerbate for 4 months. The patient received PCI uh, to 2005, and also more than 10 years later found the uh, RC stent is totally occluded, but PCI to RC failed. So this checks angiogram. So we can see this RC is mid part of RC is total occluded. But here is the former stent. So here. Because the patient received PCI in local hospital, we can see here some damages. So we stopped the procedure. 6 months later, the patient come back again, so it's recovered. Then I decide to try to open his RC. So you can see his RC is in stent occluded. So first I choose pilot 150, but it's very stiff and very hard. The wire cannot push advancement. So change to Gaia third is also, you can see here, it's very hard, so it cannot push. And then I changed to Conquest Pro. The Conquest Pro can push, but it's very hard. When push the proximal cap, the wire can advance. But during procedure, I changed 3 Conquest Pro wire because it's very hard and very stiff. The wire, Conquest Pro wire, is damaged. So I choose after 3 wire, Conquest Pro wire. I push the wire to the distal artery. So we can see it's still very hard and stiff. And then I use Godzilla assessment to uh, to strengthen the backup force. So here we can see even the wire can go to the distal artery, but the microcatheter cannot push forward. So this even under the backup of the Amplas guiding catheter and Godzilla assessment, the microcatheter still cannot push forward. I try again and again. You can see this here. You can is very hard to push forward because the proximal cap is very stiff. Yeah, many times. So you can see. Yeah, here the microcatheter, a cochlear microcatheter cannot push forward. Then I use one point balloon to dilate the proximal cap, but the 1 point um, balloon cannot cross like this. So I use bomb technique to dilate the 1 point balloon, make it rupture. But even after this, the microcatheter cannot push forward again. So how to do this lesion? And then I pull out the conquest screw and to push forward again to make a wiring channel. When I make a wiring channel, then I manipulate the rotation wire to cross the conquest screw wire wiring channel to the distal. Then we start rotation hysterectomy. So many times, I forgot how many times, but finally, we successfully to across the lesion. And when after rotation hysterectomy, then I use a balloon to dilate the lesion from distal to the middle part of RC successfully. Then I check the IVUS. So it's found very heavily calcified in the stent, restenosis plaque. So I use an SE to deal with the lesion again. At last, I use DCB to deal with the lesion. So this is the last result. So from this, we can see in the very heavily calcified coronary artery lesion, first we can use CT scan to check the calcium score. If it's more than 400, sometimes more than several thousand, so we can try the balloon. If during the procedure the balloon can cross the lesion, we can use balloon dilate. Yeah, and if the balloon cannot dilate well, then we choose special balloon like NC balloon, cutting balloon, NC balloon, scoring balloon, like this kind of balloon. But if still cannot to dilate the lesion, then we can choose the IVL, RE, or OE, or like this kind of or laser. And if the balloon cannot cross the lesion, we can choose RE to make a channel, then to deal with the preparation the lesion. So from this, we can see the heavily calcified lesion is still challenging for the PCI procedure. So we can make good preparation for the lesion is very important for us. So thank you.
Thank you, Dr. Zhou. We are already behind the schedule. Do we have time to discuss?
So any comment? Please.
Yeah. Okay. Can I ask Dr. Kasim? In complex ACS, could you elaborate more with the complex case using when you use OCT and which one that you prefer to have IFUs as the guidance?
Thank you for your question. Of course, it is very important. The old concept was fearing from using of the OCT in the acute Crohn syndrome, especially STEMI. There was false belief with clearance of the contrast, it can inducing the distal embolization. But this actually proved by many studies, it is not practice that OCT and the clearance imaging in the acute Crohn syndrome with thrombus burden can induce distal embolization. Of course,
Okay.
when there is complex anatomy, as I mentioned in the first two slides, if there is a huge burden of thrombus, complex lesion in addition to more complex anatomy like ostial part of LAD or distal left mean complex lesion, we should use OCT. OCT is now proved to be more good results in comparison to IVUS, except in the area of ostial left mean. So in big vessels, we should prefer to use the IVUS because deep penetration of the IVUS is much more with the IVUS rather than the. But most of the lesion in the acute Crohn syndrome, which need to be clearly highlighted, is superficial lesion. So we need OCT for high resolution of superficial layers, including the whether calcification or plaque or all are in the intimal layer, which can be accessed by the OCT.
Okay, how about in the primary PCI in STEMI? Do you recommend every STEMI need intravascular imaging guidance?
No. It is until now, despite the recent recommendation of the European guidelines 2020 plus 1A recommendation now, which is actually very great progress in the recommendation of imaging and the complex as a not yet recommended. The European guidelines recommend in a special situation, patient having culprit lesion, but typical patient having haziness or eccentric lesion or high burden of thrombus or multi-vessel, and we don't know is the culprit diffuse ECG changes. So it is not all patient, not routine recommended for every patient during primary PCI.
Okay, thank you very
In
much.
selected cases.
Yes, thank you. Great. Thank you very much.
Thank you.
Yes. Okay, about Dr. Donyin, when you use IFOS to guide antegrade re-entry, what we are worried is the huge intramural hematome caused by IFOS catheterizations. Moreover, using the long tips of IFOS. So how you deal with such a potential challenging situation?
Excuse me, pardon?
Yes, you get my point, Dr. Dongyi?
Yeah, I can hear you, but I did not get your point. Sorry.
If you are using IFOS to guide antegrade re-entry in CTO,
Yeah.
and then most of us using the Boston IFOS, which is very long. We don't have any Japanese IFOS, so which is very short tip. So in that point, if you are using a long tip of IFOS to guide antegrade re-entry, inserting the IFOS in to re-entry the wire, it means that the consequences is the intramural hematoma. So what you think about that? Yeah.
Yeah, I think so. Because we have multi technique to open the CTO. We can use the retrograde approach very frequently. So use the hours to guided reentry is sometimes for me is final choice. So if we failed to use the retrograde approach and we failed sometimes the ADR, then we will choose the ARVAS reentry because the ARVAS reentry sometimes I will consider the hematoma, and sometimes we need more experience about the ARVAS. Yeah.
Okay. Thank you.
Thank
To
you.
Dr. Lee and Dr. Zhao, could replace, I have two questions. First, could we replace atherectomy with IVL in severe calcification, especially when the balloon could be inserted? When the balloon could be inserted, I mean that the IVL can be inserted. Would you would you think that IVL can replace all the severe calcification at that point? And the second question, we know that it is challenging to have optimal minimal stent area in dealing with eccentric calcification, even you did atherectomy procedures. So what your suggestion to have optimal MSA in eccentric calcification? Thank you very much.
Okay, so and at first, and first question is IBL is I think IBL is very good option and may replace the other atherectomy option if the balloon it can pass the region, but and IBL is not only modification device, not atherectomy. So if there is huge calcium burden and IBL may sometimes may not effective on and sometimes we cannot reduce the calcium burden and without the atherectomy. So and especially in the ostial region like the LAD ostial and circumflex ostial. So so I think the and we we need to consider the then an optimal region and for IBL and atherectomy. And the second question is that I'm sorry, and what is the second question?
It's about the optimal MSA,
Okay,
minimal
okay.
stent area in
Okay,
dealing with the eccentric calcifications. Yeah.
Okay, thank you. In the eccentric and calcification area and region, and it's still challenging, and sometimes we are not we are not able to operate effectively to with the orbital or rotational atherectomy. I think area is very important, but not also and also the eccentricity is also important, and I think and it is still challenging. I think we need I'm sorry, we don't have in the clear answer, but still we need to modify the eccentric calcium with the some atherectomy or some lithotripsy. Thank you.
Okay. Dr. Zhao, please.
Oh, thank you. I agree with Dr. Lee. For some very heavily calcified coronary lesion, I think I prefer and also I suggest that we can use the imaging, intravascular imaging to evaluate the whole calcified lesion. But in some, in some situation, we cannot push the imaging, the intravascular imaging catheter forward, so we cannot to check the lesion. At that time, we still have some choose. We can use sometime we can use laser to deal with the lesion. Sometimes we can use rotation atherectomy to deal with the lesion. But because we have many tools and technique to deal with classification, they have some many their single characteristics. Usually, some by laser in very long classification, the laser is very low efficiency. We can use a rotational rotation accuracy. But if the calcification, I mean it's very the calcified the circle is very large, larger than 3 millimeter, then we can choose IVL to deal with the lesion. So for calcified lesion, I think the optimal preparation of the lesion, and we choose the right technique and the right device to prepare the 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 the, the lesion is very important. So this is my suggestion. And the second is also with the very heavily calcified coronary lesion, we make a very optimal preparation before we stenting. Uh, uh, then we can get the better MSC.
Mm.
So thank you.
Okay. Yeah, thank you. Yes, please, and from any other speaker, would you have some discuss about the other point of view?
Actually, I have some question. I need some
Yeah, please.
suggestion from just everybody. Uh, we know in the heavily calcified lesion, we still have now a very, I mean, the challenging tough case like the nodule calcified nodule. Until now, I think we have now still have no very or the technique to deal with the nodule. Even we use IVL, even we use RE, even we use OE, the nodule still cannot be deal with the it's very satisfactorily. So as your experience, how to deal with the calcified nodule?
Okay, please, Dr. Lee, maybe you have yeah.
Okay, and thank you for your good, very important suggestion and question. And as you mentioned, and culture nodule is the very tough case, and on the sometimes when we can get the good enough expansion and with stent or with balloon, but few months later and culture nodule again protruded. So, and I think some. We don't have clear answer, but I think some calcified plaque reduction might be more important than the shock wave and some modification. I think some atherectomy might be more effective and than a simple ballooning or simply cutting balloon or modification spotting balloon. But other researchers said atherectomy is not effective to the culture nodal region. So I don't have clear answer. But then in my hospital when treated the culture nodal region, we use routinely and atherectomy device like orbital or rotational atherectomy. So far that is our answer.
Okay.
I can add short comments
please.
about the calcium nodules. Of course, it is and still not solved yet. But what's recommended for treatment of nodule is to be aggressive by IVL. We should use 8 cycles, full doses of IVL for the nodule. If we use only 1 cycle or 2 cycle, it effective because we need more aggressive IVL to make fracturing of this nodule eccentric in one side and more cycles of IVL for nodule. Yeah, in some cases we can use both combination lys or IVL both in this nodule as well.
Okay, is there any threshold? How thick is the calcification could be cracked by the IVL? Because we know that for the cutting balloon or scoring balloon can be it can crack in the 400 micron, but in IVL could it crack in more than 1,000 micron?
I have
Yeah.
no, no, I don't have clear answer. But from Japan, one article published the one article reported the OCT study after IVL and calcium fracture was more than 500. I don't have the I don't know the exact number of the micron, but
Yeah.
and one report from Japan and said that the IVL can crack the calcium but I think further study report the optimal and the cutoff of the calcium thickness for IVL and IVL for the calcium fracture.
Yeah, because we don't know exactly until nowadays the threshold of the IVL can crack the thickness of the calcium. Moreover, in the calcium nodule, which is eccentric calcium, which is very thick calciums, whether we can crack with IVL alone or we need atherectomy, the bulk first and then followed by IVL.
Yes.
Okay, I think this we can conclude these sessions. Thank you all for being part of today engaging and insightful session on intravascular imaging in complex PCI. We have covered a wide range of important topics from mandatory use of intravascular imaging in complex SCS PCI to the critical role intravascular imaging in CTO PCI and calcified lesions. Our speakers, Dr. Ahmad Kasim, Dr. Donjin, Dr. Cholmin, and Dr. Jizal, have shared invaluable insight that will undoubtedly enhance our clinical practice in managing complex coronary intervention. Before we end, I'd like to thank again to the speakers and for the outstanding presentation, and special thanks to the organizing committee for organizing this educational meeting. And we also thanks to all online participants for your attentions. We hope you leave this session with new insight that can help in your clinical practice. Stay tuned for the next session, and we look forward to seeing you at the future meeting. Thank you, and have a great day ahead.
Thank you.
Thank you. Thank you.
Yeah, thank you.
Thank you. Bye. Thank you.
Thank you.
Yeah.
Thank you so much.